हेलो 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 कहाँ है? हेलो हेलो ठीक है
यस सर,
ओके।
यस सर। यस सर। So welcome all of you on a chilly and rainy winter evening. So thanks for coming. And at the outset, we will have a short inauguration, lamp lighting ceremony, not too many speeches. So I will request the chairman, Dr. BK Singh, past chairman, Dr. AP Mishra and Dr. MPS Chawla, and Dr. Sandeep Garg to please treasurer. Treasurer is also supposed important point to please come forward for the lamp lighting. Well, thank you. I will request Dr. BK Singh if he wants to say a couple of words.
Good evening, everybody. Dear esteemed physicians of NCR and other regions, it is my privilege and honor to address you as President of Delhi API. Together, we form a community dedicated to advancing healthcare standards, sharing knowledge, and serving people of our great city. As a healthcare provider, we must stay vigilant against healthcare challenges. Recent reports from China has highlighted a rise in human metapneumovirus infection, which are causing significant concern due to their impact on public health. There is a panic and share market crashing. But as we know, this virus is not new and not as infectious and fatal as COVID. This message must be shared to public, but we should be also vigilant. It is crucial that we remain alert and prepared to identify, manage, and mitigate any possible spread. There are other health challenges like poor air quality index and seasonal illness as well as chronic illness. As we navigate these challenges, let us also continue contributing to our shared mission of excellence in patient care, medical education, and research. I invite you to participate effectively in our upcoming initiatives, conferences, and workshops to strengthen our collective response. Thank you, one and all.
Thank you, Dr. BK Singh. With that, it reminds me that the annual CME update is planned for 5th and 6th April, API Delhi State Chapter annual CME. So all of you are requested to keep on track on the website. We will update it soon. We have just got the bookings done. And this COSM CME program, we are having, this is the main center and we are having 10 satellite centers. So one in East Delhi, which is moderated by Dr. Vijay Arora, Dr. Swathi Jami, Dr. Pankajan Chaudhary, Dr. Paras Sangwal, and Dr. Ravinder Pal Singh Makkar. Then we also have at North Delhi, Dr. Anil Gombar, Dr. Rakesh Sood, Rajiv Gupta, Dr. Sandeep Pinglani, and Dr. Rajiv Diwan will be there moderating the sessions. Then we have in West Delhi, Dr. Prabhat Sinha, Dr. Ishu Mishra, Dr. Gunjan Agarwal, Dr. Sanjay Arora, and Dr. Vinod Khedarpal. They will be there moderating these sessions. So these sessions are being telecast there. At Ghaziabad, we have Dr. Y.P. Singhal, Dr. Roli Bansal, Dr. N.K. Soni, Dr. Ram Kapoor, Dr. Rakesh Goyal, Dr. Prakhar Garg, and Dr. Pravesh Gupta. Similarly, at Noida, we have Dr. S.K. Chakravarti, Dr. Ajay Agarwal, Dr. Meenakshi Jain, Dr. Sanjay Mahajan, and Dr. Gulab Gupta. At Gurgaon, we have Dr. Ravindra Gupta, Dr. M.K. Singh, Dr. Rajesh Baveja, and Dr. Sumit Wadhwa. At Faridabad, we have Dr. Praveen Malik, Dr. Abhilash Kumar, Dr. Anurag Agarwal, Dr. Surinder Meena, and Dr. A.K. Tudeja. We had initially planned these 8 centers only apart from Habitat. The response to the program was so much that we had to add 2 more centers at Ludhiana and Rohtak. So we hope that we will meet these standards. So at Ludhiana, we have Dr. Suman Bali, Dr. Pankaj Seth, Dr. BTS Kahlon, Dr. Arish Bali, and Dr. Amit Madgil. And at Rohtak, we have Dr. Ashok Gupta, Dr. Deepak Jain, Dr. Tarana Gupta, and Dr. Hitendra Kaushik. So thank you, the moderators at different centers, because they will be conducting the sessions. And I understand with the live proceedings here, there is always a hitch, but yes, that is the advantage of technology today, that sitting here, we can telecast everything to at these 10 centers in the vicinity of Delhi. And we look forward to expanding it to the North India and then to the whole of India. So with that, I will move to the first session, and I will request the chairpersons. Dr. A.P. Mishra would be chairing the first session. Dr. Upadhyay. Dr. A.P. Mishra is past chairman, API Delhi State Chapter. Dr. Upadhyay was the vice chairman. He is still on the governing body of API Delhi State Chapter. Dr. Jasmine Parihar is neurologist at AIIMS, New Delhi. I will request all 3 to please come on stage and chair the session. Dr. B.K. Singh.
Hello. Good evening, everybody. So let us start our scientific session. And the first topic is non-invasive neuromodulation in headache disorder and update. And the speaker is none other than Dr. Devasis Chaudhary, a renowned neurologist. Introduction will be given by Dr. Mishra.
Dr. Devashis is a professor and head Department of Neurology at prestigious G.B. Pant Institute of Medical Sciences in Delhi, and he is a keen researcher, and I think not only in Delhi, all over country people know him, and so we are lucky to have a wonderful talk by Professor Chaudhary.
Right. So thank you, Chairperson, sir, Madam. Good evening, ladies and gentlemen. So I think this is a very good initiative that, you have crosstalks between medicine and other specialities. And to start the meeting with a topic on headache is really a welcome move, because headache has been a neglected topic both during MD and NDM day, curriculum, and we hardly get any teaching about headache disorders. Although in our clinic we see at least 40 to 50% of the patients are headache disorders. So what has come, I chose this topic of neuromodulation, and that too a non-invasive neuromodulation for headaches, because this actually is very important from your practice point of view. Because you see that, so first of all, I have this disclosure, there is no funding is received for any of the device makers. None of the companies. I have got stocks for any of these companies or not many of my relatives. So there is nothing personal about it. It is just scientific that I'm going to discuss. So why neuromodulation devices? So see that both acute and preventive pharmacological options for various headache disorders are suboptimum in terms of efficacy, tolerability, and cost. Although we have advanced quite a lot in the term of CGRP antagonists, monoclonal antibodies, but they still have a limitation, right? And especially the cost may be a very, very important factor in Indian setting. Then excess use of acute medications may cause medication overuse headache. It can give rise to another type of headache, which is known as medication overuse headache. Certain population may be particularly unsuitable for drug treatment, for example, pregnancy, children, adolescents, and elderly. And many headache patients, and you must bear with me for this, that many headache patients actually do not want to use drugs and seek alternative therapies, and they go to homeopathy or Ayurvedic and things like that. So you need to have something to offer to them, and there comes the role of neuromodulation. Now, neuromodulation can happen in both ways. One is a peripheral nervous system neuromodulation, and one is central nervous system neuromodulation. Now, so if we want to know about that, we should have some basic idea about the neurobiology of headache disorders. So this is the trigeminal pathway, So anything that is actually being conveyed to the brain has to go from two processes, two ways. One is the trigeminal system, which is anterior of the face, right? First division, second division, and the third division, or the greater occipital nerve, which is basically formed by the dorsal root ganglion of C2, and that carries the information from the back, right? And these two actually converge at the cervicomedullary junction. Is called a trigeminocervical complex. And in that process, we have got two important structures from periphery. Therefore, there is a trigeminal ganglion, which is going up. And there is a sphenopalatine ganglion, which forms a loop of parasympathetic system. So what we can do is this, that we can have this entire system of the peripheral, which can be modulated in some way or other. Or once we go into the brainstem and move up, actually, then the entire brainstem pain structures can be modified in various ways, including hypothalamus, thalamus, and the cortical surfaces. We'll come to that. So it can be a central or peripheral neuromodulation. So this is a very simple concept, to state it very simply, but this is a useful concept that there are peripheral neuromodulators and there are central neuromodulators. So now we give some examples. Like if you have some peripheral neuromodulation can happen starting with the vagus nerve stimulation. You can have an occipital nerve stimulation. You can have supraorbital nerve stimulation. You can have a sphenopalatine ganglion stimulation, whereas some central mechanisms may be because of the transcranial direct current stimulation or deep brain stimulation or transcranial magnetic stimulation. So we will discuss some of this today. Now, the device types can be non-invasive or invasive. You can actually go into the brain, you can go into the ganglion and then activate them, modulate them, or you can just do from superficially by anatomical landmarks by using certain devices. We'll come to that. And it can be both for the acute treatment of headache disorders and preventive treatment of headache disorders. So the description of these devices, I'll go one by the device description. Then what is the indication, rationale, evidence, tolerability, and the cost. So let us start with the peripheral. The first thing which is available in India is a transcutaneous supraorbital nerve stimulation, which is known as Kefali device. Now, this is approved in 2017 and later on for 2014 and later for 2017 for acute treatment of migraine. Initially, it was for migraine prevention. And actually, this was the first model, and then now this is a more swaggy kind of second generation Kefali device. So there are three versions that are available. One, and these models work by using an electrode that is applied directly to the forehead, right? So the prevent model consists of daily 20-minute sessions with low impulse frequency of 60 Hz. An acute model consists of 1 hour session as needed at a high impulse frequency, that is about 100 Hz. Both settings have a pulse width about 250 microseconds with a maximum intensity of 16 milliampere. So the patient puts it over the head and then there is a stimulator and there is a there is a mechanism to make it on, and so it starts giving the electric currents. So basically it modulates the trigeminal pain pathway, right? And it is actually based on gate control mechanisms, as you have known in our MBBS studies, that there is a gate control theory of pain transmission from the peripheral to the central CNS structures. Now, in acute setting, it is also known to produce a kind of a sedative effect, whereas in prevent setting, it restores the normal brain metabolism in the frontotemporal cortex. So what is the evidence for it? The first study that came out, it was called the Premise study. It showed that compared to the sham group, the Verum group, that is the actual device group, they performed much better, and the 50% responder rate was to the tune of about 40%. So that got the approval because of this, and then came a proper randomized control trial called the ACME trial, and that also showed that there was a relative change in the pain intensity at 1 hour for the acute medications, and relative change over 1 to 2 hours again favored the device compared to a sham stimulation. In sham stimulation, you give the stimulus, but at a much milder intensity and at a much lower frequency. So therefore, that just gives as a placebo kind of an effect. So there is also use of Cephalli in Japanese patients, so in Oriental patients also, that has also shown good results. So based on that, it got an FDA approval, and now it has been in India for some time. It cost about $10,000. So you can, if the patient can afford, one can, actually, and the stimulator is useful for about a month of stimulation, and then it can be, again, refilled. Now, this one is a combined occipital and supraorbital transcutaneous nerve stimulation. This is a new development. As I said, that there is at the back, there is a greater occipital nerve. And so this device is known as a Relivion. So this is now available in US and Europe. I'm trying to get it in India, and maybe that in coming year we can get it. And then there are other variants of this cephalic device like Hedaterm and things like that. So it has been shown that even if you have it in the emergency setup, when the patient visits to either clinic with a severe headache or in the emergency with a severe headache, you can actually apply this and give relief to the patients. There is some evidence that Cephalli may also work for tension type headaches and vestibular migraine as well. The adverse effects are minimal except for the paresthesias because of the electrical stimulation. And of course, it cannot be used in patients who are allergic to acrylate or have skin abrasions or having some infection in and around the face or the trigeminal distribution area like ophthalmic shingles, etc. There is the second device, which is called a mastoid device. Now, this device is a small patch which is kept at the back of your head in the mastoid region, and there is a stimulus. So this was actually, started some time back, but actually it has not hit the market. Somehow this got, there were, when these kind of devices are developed, they are developed by innovators, but to come to the market takes a long journey, and that's a problem with most of the neuro devices. So it is not yet available, but it might be available, and it has found to be useful in the preventive treatment of migraine. Then there is Chinese kind of groups have actually advocating this small needles with electrical impulse passing through that. So this is called electrical acupuncture, and they have shown in some studies that they are useful, but generally not well kind of conducted studies, and therefore there is a lot of query about this. So they are also not very popular, but they have shown very significant results. And probably, some people who are actually doing an acupuncture may also be, in the know-how of how this electrical acupuncture works. But the most interesting development has been this vagus nerve stimulation, which is known as gamma core. Now, this was the earlier model, and this is the latest model. It is developed by a USA company, and it is out, externally, you are actually stimulating the vagus nerve on either side of the neck, right? And it is first cleared by FDA in 2017 for episodic cluster headache. Then it was cleared for acute management of migraine and as an adjunctive use in the prevention of cluster headache in 2018. So each of these indications involve a series of 2 minutes of stimulation. So you have this device for acute migraine. You have got the 3 treatment, kind of sessions, And it's a 2-minute stimulation at the start of the pain, 20-minute wait from the start to treatment 1. If the pain remains, then 2 more 2-minute simulations you can do. And it has been found to be useful. And an adjunctive for the cluster headache, again, you can use 2 treatment sessions of 2-minute stimulations using this device. And you can actually, the patient can actually make use of the, there are dials through which you can actually select the proper stimulus intensity and frequency that you need for that particular patient. And for acute cluster patient also, you can have a treatment paradigm in which at the start of the pain, there is 3 2-minute simulations, then 3 minutes wait. And then if the pain still persists, then you have 3 more 2-minute stimulations. The mechanisms are ill understood, but actually vagus nerve has got a widespread activity and actions like autonomic nervous system, decreased firing of trigeminal nuclear neurons, and acute relief of the peripheral nervous system symptoms. So it has got a multiple effects, and we don't know for sure which one is acting. But in clinical trials, for the cluster headache, the evidence is quite robust because they have all shown to be a very highly significant effect compared to a sham stimulation. But migraine, it is somewhat, one acute study has proved to be very good, but the other studies have not really done so well. So therefore, I think that mostly I get it from UK and I use for my cluster patients because they're very disable, and this actually comes handy for treating the cluster headache patients. Now, it can also be used in vestibular migraine and hemicrania continua. The most common adverse effects are at application site discomfort, which is about 4%, application site irritation, redness, local pain, muscle twitchings. Now, once you increase the intensity, there is a twitch that happens, and that can be problematic for some patients, but otherwise it's very, very well tolerated. There is other variations which are now licensed in Europe. They actually target the auricular branch of the vagus nerve, and they are put in the ear or behind the ear, and they are known as Nemos or Vitos devices. They are not available easily available because they are specifically made for some European countries. The thing which has actually changed the paradigm is this. This is called the Nerivio device, which is a wearable neural stimulation. Now, this has received the FDA clearance in 2019 in the acute treatment of episodic migraine with and without aura in adult patients, and later for preventive treatment as well. Now, this device is applied in the upper arm at the onset of the migraine pain within best results are within, if you are doing it within half an hour, with or without aura, and is controlled by a Nerivio app that is available on your iPhone or Android. And you can actually increase or decrease the intensity and the frequency of stimulation based on your requirement. So this actually works on the descending pain mechanism rather than the gate control theory, which we talked about cephaly. And actually there is an animal model for that, which is known as the diffuse noxious inhibitory control, DINIC. It is based on that, and therefore it regulates there are a lot of pain modifying structures in the brainstem, including the para-aqueductal gray, rostral ventromedial medulla, subnucleus reticularis dorsalis. So these areas, they get, the descending pain transmission, and it modulates that. And it has been found to be very useful. And this was originally the trial which showed the, positive results. And therefore it was approved by the FDA. And subsequently, a larger trial was actually shown. And then you can see that the pain response and the most bothersome symptom in acute migraine, like nausea, like photophobia, like phonophobia, they all get better by this device. So this device is now available in India. It is marketed by Dr. Reddy's, and it is costing about 12 to 14,000 rupees. Initially, it was costing like that, but now they are giving 1+1 offer with some concession in the prices. So I think it is reasonably affordable by many of the Indian patients. And the good thing is this, that it can be a substitute for the patients who do not want to take an acute migraine medication like a triptan or a G-Band or even a heart analgesic, right? And especially in pregnant female, and they should be considered in patients with a risk for medication overuse headache. We have been using it. I've got about 20-25 patients on this, and they have done pretty well. Now about the central stimulation neuro devices, this is one which is known as a transcranial magnetic stimulation. This is a single pulse transcranial magnetic stimulation. This is known as the spring device. This was the original device which was initially brought out, but now we have got the third generation spring device. It looks like this. You have to put it across at the back of your head, and it delivers a single pulse transcranial magnetic stimulation. So protocol for use is that for the prevention, twice daily treatment with 4 pulses, 2 consecutive pulses, wait for 15 minutes, then repeat another 2 consecutive pulses. And for acute treatment, 3 sequential pulses can be given at the onset of migraine attack, followed by additional pulses at 15-minute interval if needed. So how does it act? It actually shows a multiple effects because it modulates the cerebral cortical activity, and also it affects the neuronal plasticity, right? So there have been trials to support its use, and there is an evidence base for it, and therefore it got an FDA clearance, and it actually have a good response, pain-free response at 2 hours, 24 hours, and 48 hours. And then there was another study, an open level observational study. It also found that it is actually pretty good and effective. So these are the primary efficacy endpoints. 50% responded, 46% compared to 20% in the placebo. So it's a sizable effect, and the total decrease in the migraine mean medication reduction in headache days from the baseline is to the tune of about 3 days, which is very significant from a clinical trial point of view. And it has been, there have been post-marketing studies in UK. It has been shown that it is very good. But only problem is that probably because of its cost, it is many people cannot continue it because some of the NHS hospitals are not actually reimbursing it, and therefore the cost becomes prohibitive. It can be given in pregnant patients as well. The occasional features may be nausea, photophobia, phonophobia, and that might be a part of the migraine itself. It is well tolerated. Lightheadedness, tingling, and tinnitus may be sometimes experienced. No serious adverse events. So this is the mainstay for this neuromodulation devices, that you do not have a very significant degree of any serious adverse events. Of course, because you are doing a magnetic stimulation, you have to contraindications like stroke, seizures, cardiac pacemaker, defibrillator, vagus stimulator, and such electrical devices which are up in your body. Now, the other alternative is actually these large repetitive transcranial magnetic devices which are given in a hospital setting. But then, you have to call the patient regularly to the hospital and have to have technicians well trained for it to give the pulses for about half an hour. There have been some studies, and the results are, kind of a, plus minus group. So it is generally, you can see this, this is one of the meta-analysis and forest plot. You can see that the line is crossing the 0. So therefore, there are some studies which are showing good results. Some are not showing that much good result. But again, this might not be widely applicable because you have to call the patients again and again to the hospital. Then there is a device called transcranial direct current stimulator. Now, direct electrical current is given to 2 or more electrodes placed on the scalp, typically for a relatively long period of time, for example, 20 minutes. And there are multiple types and the multiple technologies that are used: conventional, high definition, individualized high definition, and they all act by various ways like polarization of neurons, neuromodulation, and changing the connectivity of the cortex. But the problem is that in order to, kind of assess them, there's so much variability because they vary as per the head circumference, location where you're putting anodal or cathodal, current strength, and electrode size. But still, a systematic review has been done and has found to be useful. And this actually is actively now taken up because this will be much cheaper than the available, neuromodulation devices, and probably it will come. There are some suggestions that it might actually work. Then there are some minimally invasive devices. One is a device which is known as a spinopalatine ganglion stimulator. Now you have a small chip, as you can see in the figure B, that this chip is introduced in the spinopalatine ganglion by a minor operation by a ENT surgeon, and you have an external stimulator, right? And this stimulator, at the onset of the cluster headache, you stimulate and your headache will be gone. So this has been actually shown that it is very, very effective in chronic cluster headache patients, and this might be quite life-saving. And this is how it looks. Like this is the spinopalatine ganglion, and this is how the chip looks inside the spinopalatine ganglion. And Peter Goadsby's study has actually shown that it is very, very useful because there is so significant effect compared to the control group. The only problem is this, that this company, after few years of operation, got busted, right? So now there's people are trying to revive it, but there's a problem in the availability of this machine. But otherwise, this is a good choice. Another thing which has come is the special injections. Like this is a particular injection. You can go to the sphenopalatine ganglion and give a Botox there, right? It is chronic intractable chronic migraine, and also in cluster headache. Now there is a neuronavigation system. By that you can actually go and inject Botox directly to the sphenopalatine ganglion. So it's a minimally invasive, but the results are supposed to be good. And so this will also be coming possibly in the coming years. And finally, the most interesting part is this, that there is one device which is known as a kinetic oscillator. Now, this is a small device. There is a small balloon here, and it actually rotates very fast when you put it across the nose. So at the start of the migraine, you can actually, it can be put in one of the nostrils, and because this is motion, it stimulates the trigeminal system in such a way that the headache is gone. So there are some reports coming in favor of this machine. But of course, I sometimes believe that, during the migraine headache pain, how the patient is going to tolerate something putting into the nose. They generally also don't like to have nasal, sprays at that time, because many of the sprays are available, nasal sprays, but some people have aversion to it. Now, the cost benefit ratio. Now, if you have these 4 devices which are available now, Gamma Core, Spring device, Cephalion. So this is the cost. And in that, and if you see the efficacy, and efficacy is like this. So you see that actually the Spring device is doing well. Also the Gamma Core, and also the, all of them are actually doing pretty well. But if you see the cost, from the cost and the efficacy point of view, I think at the moment the Nerivio device, which is costing about, which will to the patient now will cost about 8,000 or 7,000 if they get 1+1 free kind of a scheme. So that would be actually a good alternative for the treatment of migraine, and acutely as well as for preventive treatment of migraine. And I think that is the thing you should actually think, and you should actually, these people are trying to widen the net and going, now initially they started the neurologists, but now they are going to the physicians. Today only I had a meeting and I was talking to them, and probably you will be offered this to try out in your patients, and therefore you can actually use it. And it is very simple, very easy to understand. Patients are able, and most of the patients in India are having this advanced phones, and so they can easily do it. And this will be a good armamentarium in your basket to treat migraine, both acutely and for preventive. Thank you very much for your kind attention.
Thank you for the wonderful talk, and I'm happy to know that some of these devices are available in India, and I'll be keen to use this. But I would like to know in your practical aspects, like how do you select the patient for a device?
Yeah, so that I said, one is of course the patients who are, you see, the chronic migraine is like this, like the patient starts with an episodic migraine. It's a low frequency, about 3 to 4 attacks per month. Then it goes on to become about 7, 8, and then it goes and jumps beyond 15. Some people will have 22 days, 28 days, 30 days headache every day, daily for months, for years, right? So these patients, what they do, they actually consume a lot of, medications, acute medications, either in the form of analgesic plus domperidone combination, or triptans, right? And they develop a cycle of these drugs, giving some relief for some few hours or for a day, and then again coming back with the headache. So they create a situation of medication overuse headache. Now, these are the patients where you want to decrease the acute medication. How do you do it? You tell them, you say, no, sir, I can't live without this. How can I? At least it is giving some relief. So then you actually, what you do is this, you can offer this device, and this device will curtail significantly on the drug usage, right? Because they are going to get the relief within about half an hour to 45 minutes of their acute headache. So the intake of that acute medication will decrease. That is one. Second, pregnant patients, right? Third, a lot of youngsters, they don't want to take this analgesics, patients with a gastric problem, patient who are averse to taking triptans, for example. There are a lot of young migraine patients I see, they have hypertension already, right? So we don't want to give, triptan to them. So these are the patients where this can be safely given. Patients with cardiovascular risk factors, cerebrovascular risk factors, a family history of stroke or MI. So these are the patients where you can actually very safely give this device, and the patients can do very well. So this is one. And secondly, some of the patients who need a preventive, but they don't want to take a medicine for a long time, they might prefer this kind of, device in which they will apply it twice a day, and they will not need the drugs. So this is another group of patients who can actually benefit from it. So
Right, any of these treatment naive patients?
no, so treatment naive patients. So as a you can actually you can only initially your main aim is to decrease the headaches as fast and as quickly possible. So you will go in for a class 1 evidence drugs, right? But if the patient says that no, I don't want to take drug, yes, I have given about 3-4 patients who didn't want to take drugs from the beginning. I said, sir, I don't want to take any drugs. Give me something else. So I've given that. But as such, I would not prefer to give it as a first go, because I would like to give them the maximum benefit, which are established treatments. And I know that a triptan is going to definitely bring their headaches down within a short time. So I would go for an established drug. But yes, it can be given in certain situations. And you can also ask that whether independently, how much effective are they independently without the drugs, right? So that is a question that we'll see on the post-marketing, experience. But generally, they curtail the drug intake quite significantly because of the use of these devices.
Okay, I think now we can take questions from the other centers. If I am audible, if they have any questions here for Professor Chaudhary, they can ask the question. I'm talking to the other 10 centers which are seeing this program live. If not, okay. Let me ask the Professor Chaudhary, this vagal stimulation, will it cause bradycardia or that kind of thing?
No.
Or a person will go into certain problems?
So that was a kind of a concern raised initially by the researchers, that whether if you stimulate the vagal nerve. Now, vagal nerve stimulation, invasive vagal nerve stimulation has already been performed for epilepsy for a long time now. But this is non-invasive. This is from outside through a machine. It doesn't cause any bradycardia or any kind of a hypertension, any cardiac effects so far.
So from Gurgaon, can I ask a question?
Yeah, please go ahead.
I'm just in the cluster headache patients with high flow oxygen, the response to the patients is almost 80 to 90%, which is quite significant. So
Yes.
how much is the role of this gamma core in then? Because 90% patients, they respond to high flow oxygen.
Yeah, so you are right. So that's what I said, that, we are talking about this neuromodulation devices. We are not actually replacing the standard treatments, but we are actually adding the high flow oxygen again depends on availability, right? A person, suppose the patient gets an acute attack during his workplace or during at a place where he's not having an access to the oxygen therapy, right? In India, the portable canisters are not available, just like in UK and US, right? So he has to go to a nursing home or to a hospital for getting this 100% oxygen. So then in those cases, these devices act. But more importantly, there are a subset of 20% of the cluster headache patients actually develop a thing called chronic cluster headache. So they do not respond then to oxygen. They do not respond to sumatriptan. So in those patients, these devices can be either as an alternative or as an add-on to the existing treatment.
Question from any other center?
So,
Kumar, you want-
this side is Paras from East Delhi. I just want to learn what is the exact mechanism and how is it different from Reiki and acupressure that we use otherwise.
Mechanism of?
Acupressure and Reiki that we use, they also cause neuromodulation.
Yeah.
How is it different? What is the final common pathway, or is it different?
So I don't know about the acupressure and Reiki, but probably, so brain is in a constant state of dynamic flux. So when you are actually having the sensory perceptions, either in the form of touch, smell, hearing, or vision, So brain is already, there are a lot of neuronal circuits which are active, right? For the pain particularly, when you actually have the stimulation of the trigeminal system as we know today, they follow a certain route, right? But that route is not limited to that particular kind of diagrammatic way that I showed it, because it spreads to entire cortex. So all these devices in some way or other affects the transmission and the excitability of neurons in the brain, either in the cortical level or at the brainstem level, right? We don't know yet exactly that how exactly that is happening. We are getting there, but we don't know exactly. But possibly that is happening, and same is possibly happening through meditation, yoga, yogic practices, meditation, and also I don't know about acupressure, but Reiki, yes, Reiki is another form. So probably the neuronal plasticity, as we call it, the ability of the neurons to adapt to these dynamic changes and function differentially based on these inputs, that actually plays a role, and that probably is the reason and the underlying mechanisms for most of these devices. But these devices are based, the peripheral ones are based on a particular pathway. As I showed it, either supraorbital nerve or the greater occipital nerve, something like that, or the vagus nerve. So these pathways are well known, at least experimentally proven pathways for generation of migraine pain and the cluster headache pain.
These devices should be used lifelong, or is there any mechanism where
no
permanent?
So I think that just like headache medicines, you always this question, how long should we take? You should take till the time the patient is symptomatic enough to cause a disability, right? So if there are less 3 or 4 attacks only per month, then you can just treat with acute. You don't need preventive, right? If the attack frequency increases, you need the preventive, and depends on the patient needs. Many of our chronic migraine patients are on years on medication. They just don't want to leave because they know that once they leave, the attacks are going to come back. So there are that group of patients also. But by and large, you would give a trial of about 6 months to 9 months of these medications, and for the episodic form, and you would then try to withdraw the patients from the medication or the devices. That is the usual dictum that we follow.
Dr. Devashish, this is East Delhi Center. I have 2 questions. One is, do you have any personal experience of using CGRP antagonists?
Yeah. So I did the international trial after which the CGRP was introduced in a country called Erunumab. So that is called the Empower trial. So I was the principal investigator, or one of the principal investigators from India. So that has been published. So I have been using Erunumab also for quite some time now, and also I have some of my friends have sent samples of Galcanezumab, and that also we have used, and also Lilly trial Galcanezumab also I am the principal, and that has also been published. So I've got a good general impression about the maps, and they are very good because once in a month injection, and you don't have to take anything, and at least 60% of the patients are going to have a very good response, 50% responder rate. So, and some of them have dramatic changes, right? If the patient from 30 attacks per month will come down to about 2 attacks per month. So some people can have a dramatic, but there are patients who do not respond, and that will be about 25 to 30%. And in that group, we have to devise other ways, but generally, and they're very well tolerated, except for Erunumab causing a little bit of systolic hypertension. You have to be careful about that, and constipation. These 2 things. Besides that, they're generally very well tolerated, and patients generally, once they get to use this, they very much like it. And about the duration question that is asked, even for the maps in the West, now people are using it for 5 years or 7 years down the line, and they just don't want to get it off because it's so convenient. Once in a month, a subcutaneous injection, and you are off. You don't require anything else. So that's a really game changer.
And regarding the Botox,
thank you, Professor Chaudhary. We had a very interesting talk. This is a new thing which has in our armamentarium. And as you rightly said, some mechanisms are understood. Maybe with passage of time, we will understand more and more about these things. And let us give him a big hand.
Thank you.
Thank you, chairpersons and Dr. Chaudhary, speaker. I will request the chairpersons to please felicitate Dr. Debashish with a memento. I will request Dr. Rajesh Upadhyay to please come on stage and felicitate the chairpersons.
ये राजेश उपाध्याय का तो सबसे आखिर में था।
वो फेलिसिटेट करने के लिए
सर ये अनम्यूट कर लीजिए पहले, म्यूट कर लीजिए।
म्यूट।
Well, with this, we come to the second session. Equally interesting, I'm sure. And I request the chairpersons, Dr. Pritam Gupta. He has not only been the past chairman, API Delhi chapter, but also the national API president as well as dean. Dr. Anil Vardhani, consultant physician at BLK Max. Dr. Sandeep Garg, director professor medicine, Maulana Medical College. And Dr. Manisha Thakur, consultant physician and specialist at VMMC and Safdarjung Hospital.
वॉल्यूम ऑफ करने, ऑन नहीं करने।
वॉल्यूम ऑफ था सर जब।
Good evening, friends. The next topic is a very interesting topic, especially for the physicians' point of view. Management of heart failure across the ejection fraction. And the speaker is going to be Dr. Subhash Chandra. You all know he's a very popular cardiologist in BLK. With these words, I invite Dr. Chandra.
Thank you, sir. Let me thank API for this initiative. And it's really heartening to see such a large audience here and at peripheral centers. And Dr. Chawla, they're legends sitting here. So it's my proud privilege that I'm allowed to speak here on heart failure. Without much ado, because sessions are taking a long time. So we'll try to, stick to So the context setting about heart failure versus atherosclerosis. The atherosclerosis would cause MIs and strokes. On the other extreme, heart failure leads to death and recurrent hospitalization for heart failure. And if you look at these two charts, there's a starking reality here that the mortality of heart failure is much higher than with strokes and MIs. It is said that at the end of 5 years, almost 50% of patients suffering with heart failure would succumb, which is much higher than many cancers, be it cancer prostate in man or cancer breast in women. So, and today, the heart failure is classified based on ejection fraction, which is a very important parameter, though with a lot of fallacies, because it is a tool which is done by a lot of subjectivity by various operators. And it is also impacted by the conditions of the heart in a case, heart rate, the loading conditions, and various physiological parameters. But yet, it has emerged a clear tool to prognosticate heart failure and to predict the response of various therapies which are given to treat heart failure. So we all know, and I'm sure my astute physicians sitting here, they've been treating heart failure day in and day out. Anything less than 40% is HFrEF. The mid zone is 41 to 49%, and more than 50% is heart failure preserved ejection fraction, which was a neglected entity until late, when we realized that this is an entity which is present in society almost in 50% of heart failure patients. Well, when these patients are kept on treatment, a lot of them improve, and that is categorized as heart failure improved ejection fraction. This is a busy chart, but the latest classification of heart failure says that heart failure is not just about panting and losing stamina, but it starts much earlier, as in stage A, where a lot of risk factors for future heart failure are present, as in case of hypertension, diabetes, underlying severe risk factors, dyslipidemia, a lot of cardiotoxin agents like alcohol, or various genetic conditions. And it is the onus lies on us to recognize them in time and initiate therapies like controlling blood pressure or starting an SGLT2 inhibitor if patient happens to be diabetic, so as to prevent future heart failure and renal disease, or if he has dyslipidemia, treat it to the level where LDL could be knocked down to as low as 70 or 55. Identify genetic conditions, and patients who are suspected to be suffering from some kind of dyspnea, you must not hesitate in ordering an NT-proBNP estimation, because that's the first tool which can give you a lot of guidance whether the patient has underlying heart failure or not. And then going on to the stage B, where the parameters of heart failure are present, though patient may not have obvious dyspnea, but anybody found to have ejection fraction less than 40% on echo is clearly suffering from a heart failure. And if you exert him, he definitely will be found defeated. So therefore, in these cases, the four foundational pillar therapies, which all of us practice in our day-to-day life, is the ACE inhibitor in the beginning, which has been virtually replaced now with ARNI after the Paradigm heart failure trial. And of course, beta blocker, which is the most robust mortality benefits in heart failure with residual ejection fraction, anybody having EF of less than 40%. And then MRAs were there for last decade or 2 decades, which were beneficial. And the new kid on the block was the SGLT2 inhibitor, which emerged a clear winner and literally revolutionized the treatment of HFrEF. So we all have been using these molecules in the eligible patient. Then comes the obvious heart failure, where patient is clearly suffering from dyspnea, has lack of stamina, ejection fraction is found to be less than 40%, and he qualifies to be HFrEF. It is here that we initiate these 4 foundational pillars based on their underlying hemodynamics. And then we wait for some time. Of course, diuretics are the mainstay of decongestion and symptom relief without any mortality benefit. So one should try to minimize diuretic use as much as possible, because that will impact the cardiorenal system. And the renal function will be impaired if you keep on using excessive diuretic in these patients. Rather, they should be replaced with 4 foundational therapies which have mortality benefits. Go on to see the ejection fraction step 2. If it has improved, then one must continue with all lifestyle measures as are shown here, and the medications as was shown here. We have no right to de-escalate or withdraw these medications if the ejection fraction is improved. There's enough proof that if you withdraw these therapies, patient will go back downstairs and will have worsening heart failure. If the ejection fraction continues to be low despite these 4 foundational therapies, one has to clearly look at additional factors, as in black patients, combination of isolazine, could be beneficial. They could be considered for prevention of sudden cardiac death by giving an AICD. Or if they happen to have white QRS, as in left underbranch block or interventional conduction defect with ejection fraction of less than 35%, they are most eligible candidates for cardiac resynchronization therapy, which is called as CRT. And if you combine it with defibrillation, it becomes a combo therapy or CRT-D therapy, where the ejection fraction improves with CRT and the sudden cardiac death is prevented by implantation of AICD. Going on further, combination of hydrazine nitrate could be added, ICDs, CRTs, and if patient progresses to refractory heart failure stage, there are revolutionary therapies today in the form of mechanical cardiac supports, as in LVAD or cardiac transplant. If there are underlying causes in the form of MR or aortic stenosis or any valvular disease or coronary artery disease, they should be given ample treatment. There are a few additional molecules which could be used in the form of ivabradine if heart rate is yet high in spite of using best tolerated beta blocker. One should use ivabradine 5 milligram twice a day to bring down heart rate to less than 70 or so. Vericiguat is the fifth pillar of therapy, which in patients of worsening heart failure, despite these four foundational pillars, could be started with 2.5 milligram daily of vericiguat, escalated to 10 milligram daily. And it can do wonders in terms of reducing heart failure hospitalizations. Digoxin is another drug which has gone out of fashion, but it should be given to all AF patients who control ventricular rate, and even refractory heart failure patient could benefit by giving digoxin in these patients. But mind you, have to keep a watch on the digoxin level. There are various therapies like potassium binders in the armamentarium. If you happen to have hyperkalemia, by the in tandem use of MRA and ARNI, potassium binders, and luckily in our country, Patiromer has been available of late. So they should be amply used, and various other therapies could be utilized. This is a repeat of what I said about CRT. It should be given to all HFrEF patients with EF of less than 35 and LBBV in excess of 150 milliseconds, combined with an ICD as in combo to prevent sudden cardiac death. And any patient who requires pacing, or a patient has other defects like IVCD or bundle branch block in the form of 120 to 149 milliseconds, they all could be benefited by giving a CRT therapy, or now even the LOT CRT, where conduction system could be paced so as to bring down the QRS to the narrowest possible range. So that's about the device therapies. If somebody has an MR with HFrEF, MitraClip is emerged as a very important therapy, though at a high cost. But any person with ejection fraction of 20 to 50%, LVN has systolic dimensions of less than 70 millimeters, PA pressures of less than 70, should benefit by giving MitraClip as in secondary MR. TAVI could be given to these high-risk patients to replace aortic valve. And of course, there are remote therapies to have a clue about the pulmonary artery pressures and the hemodynamic and water status of these patients. And one can tweak therapies even from home based on these smartphones. This is a busy chart which says that iron is very important tool for HFrEF patients. Patients who are having iron deficiency, which should be regularly estimated in our HFrEF, with or without anemia, would benefit by giving intravenous iron. And erythropoietin has no role here, should not be given. Sleep disorders should be treated. Obstructive sleep apnea should be treated. Diabetes, SGLT is the mainstay, and hypertension should also be treated. In atrial fibrillation, anticoagulation is a must to prevent a stroke, and especially the NOACs or DOACs now. And if patient is eligible, then AF should be ablated, which can do wonders to these heart failure patients. The appalling fact globally is that the heart failure therapy penetration is very, very minuscule and pathetic. And this is worst in Indian context. So if you see at this slide, just about 37% patients are discharged on 4 foundational therapies. And these patients keep coming back at the end of 6 months for rehospitalization, leading to high mortality. And in the India scenario, it is just about 25% of eligible heart failure patients is receiving GDMT, which has to be improved. And that's the whole purpose of including this topic in this important forum. And there are Indian studies like CSI Kerala study or Indian College of Cardiology study. All of them consistently say that in India, the heart failure patients are not getting their due because of the inertia on part of physicians, or affordability issues, or various other issues, the unwillingness. We see that these therapies which are listed here have taken many, many years to be accepted and embraced. But by virtue of smartphones and various apps, it is possible to penetrate these therapies to as wide as possible in the population. There are drugs like SGLT inhibitors, which have been a clear winner, especially in HFrEF. So in HFrEF, if you use all 4 foundational therapies, the outcomes are excellent. So start with quadruple therapy. Today, the approach is simultaneous therapy, because one should try to start 4 foundational therapies at one go, so as not to be deprived of benefit of these 4 therapies. A word about HFpEF, which is one entity which was ignored, but because of the awareness and the comprehensive echocardiographers, this is one syndrome which, because of the multi-system or multi-comorbidities, focused on to the heart, leading to dyspnea. And any obese female walking to your clinic with dyspnea You should not pass it off as a respiratory cause for dyspnea. One must estimate their NT-proBNP, conduct a thorough echo, and see whether this patient has HFpEF or not. And classically, patients who suffer from diabetes or CKD or hypertension, obesity, obstructive sleep apnea, atrial fibrillation, it is a classic subset where you must suspect HFpEF and start these therapies. And based on these scoring system, one can actually reach to the bottom of HFpEF diagnosis and initiate therapies like SGLT inhibitors. So both empagliflozin and dapagliflozin have a very robust data in this domain of HFpEF, where the mortality and hospitalization for heart failure is reduced by introduction of gliflozins in this subset of patient. We have been struggling with HFpEF management in last 20 years, where MRAs, beta blockers, ARBs, all of them have been tried, but they have miserably failed. SGLT is the only therapy which has emerged as a clear winner and revolutionized and has earned class 1A indication for management of HFpEF in the modern times. So gliflozin is one molecule which across the board from HFrEF to mid-zone to HFpEF have consistently shown the mortality and heart failure hospitalization benefits. The DELIVER trial, which was on dapagliflozin, is also replicated what was shown by empagliflozin in this domain of HFpEF. So from class 2A, it has actually emerged as class 1A molecule for management of HFpEF. Besides diuretics, which is class 1, because that is the one which relieves symptoms these patients. With that, I think I come to the end of my presentation. So the HFpEF should not be treated as a stepchild. It is as important as a HFrEF. The mortality is high, disability is high, so it should be treated in the right earnest. Thank you so much. The last word is about rapid sequencing. You should not wait, unlike previously where 6 months were exhausted in initiating one therapy each time. You should start at the first contact with beta blocker and SGLT, which would cause least hemodynamic derangement in terms of blood pressure or potassium. Go on to add ARNI thereafter, keeping watch on blood pressure. As much as it is more than 100 systolic, you should try start with 25 BD to 50 to 200, and eventually MRA carefully should be added, keeping a close watch on renal functions and potassium values. And that is the key. Heart failure should be managed in the modern times. Thank you so much.
Thank you, sir. It's a very good talk, and in 20 minutes you have summarized everything. I just want to ask the role of non-steroidal MRAs in HFpEF, which has recently come up, Finrinon.
Okay.
Because a lot of studies are coming up, non-steroidal MRAs in HFpEF.
So Finrinon is a new molecule which came in because being a non-steroidal and having least androgenic effect, and was a clear winner in the domain of diabetic nephropathy and proteinuria. But being an anti-fibrotic drug, there was always a hope because MRA have been there in the therapy of HFpEF. So there was a recent trial with the name of Fine Art, and that trial has shown that Finrinon could be one drug which could also be utilized in place of previous spironolactone or aplenon. It could be replaced by Finrinon, but we're still waiting for some more data on this, and it could be a way to go.
Till now, we have only one drug for HFpEF, that is SGLT2.
Right.
Not Finrinon.
Not Finrinon.
So, fine. Another question.
Usually the discontinuation because of the hyperkalemia. So what are the what levels and what is the frequency and the estimation of?
Right. So when we start HFrEF patients on ARNI and then followed by an MRA, there's always this fear that creatinine values will go up and potassium will go up. So until a value of 5.5, we are safe that we can continue with this, keeping a close watch on the dietary patterns of these patients. A lot of these patients have been using a lot of citrus fruits, having kala namak or senda namak or any alternative namak, which is bad, which can reduce sodium, but it increases potassium. So one has to inquire deep down that, are you using these salts? And if yet potassium is more than 5.5, then one should utilize the therapies meant for it, like the binding therapies or the petiromer are there, which is in the advanced phases. But one can always de-escalate, at least withdraw MRA for time being, or can even use the dose of ARNI. Sometimes if they are symptomatic, the addition of
Thank you so much for
torsemide
the
or
question.
furosemide can compensate for
Look,
some
as far
proportion.
as the continuum of heart failure is
But that is the way we manage.
considered,
It should be estimated at the end of 2 weeks
initially
once
there
you
was
start.
only one term heart failure.
So,
Then they divided into reduced and preserved.
So from
What is
East
your
Delhi,
take on SGLT2 inhibitor if the creatinine is worsening
Why
after
this
starting
cutoff of 50% has come?
SGLT2?
So, ma'am,
We have seen that
it is
certain
true for all these foundational therapies that once you initiate ARNI or
So as far as
SGLT,
question is
there is an initial rise
as a
in
class,
the
is
creatinine value
effective across
and
the
the dip in renal
spectrum of the
function.
heart failure.
But one should not be alarmed if it is under 50% of the
And
basal
as far
value.
if
If it
one
exceeds
particular
50%, one has
SGLT2
to stop the therapy.
most of
But
the
then the
trials
trend
have
says that
been
it rises back, bounces back, and
whether
then
it is
reaches
a
a
deliver
plateau,
trial,
and thereafter
whether
starts
it is a
declining.
pandemic
Because
trial,
eventually the heart failure starts
trials have
improving,
been done
so the renal
mostly,
function also starts
even though
improving.
there are so
So that
many
is the way one has to keep a
people
watch on renal functions. If there's an excessive derangement, then one has to hold it.
I personally feel very
do we have
comfortable.
any other questions from the other centers?
So as a class, it has a effect
So
on
I have a question to Dr.
Dr.
Subhash
Meenakshi is there.
Chandra.
Yes, Dr. Meenakshi,
preservation
please,
of the
from
heart
Noida
as
Center.
well as renal function as well
from
as
East
Dr.
Delhi,
Meenakshi,
related to diabetes or non-diabetes.
May I have your attention, Dr.
please
Personal
unmute
choice.
yourself.
Till now, there is not much studies which has been done with the remagliflozin, DAPA and AMPA. Many studies have done and they have shown almost the same results. I hope this answers it. Anyone else?
yeah.
So I have a question from Rohit.
Anybody from ESI wants to ask?
Doctor from Rohtak.
Hospital.
Yes, sir.
So I have a question. So I'm a physician at Rohtak, and about
Anyone
8
else?
months back I had a
Before we move on to
patient.
the next session, you want to say something?
So can I ask a question?
Am I audible?
Yes, yes, please carry on.
This is regarding, you have been saying IV iron therapy should be given to heart failure patients with or without anemia. Now the question is, if there is no iron deficiency or rather the iron levels are a bit higher side, then definitely giving IV iron may cause liver toxicity as well as renal toxicity. So, whether we should give it to every patient, even if it's not having anemia, we should give IV iron therapy to the heart failure.
So the question is about iron therapy in heart failure. So in all HFrEF patients, one must measure the ferritin values and the levels. And if they're found to be deficient, which in heart failure the cutoffs are high, then irrespective of anemia, as much as the hemoglobin is up to 15, it should be given. And the shots are given as 1 gram IV dissolved in dextran, followed by 3 months, another shot, and thereafter you can measure these values and can choose to give it further. And you're right, excessive iron can always lead to hepatic dysfunction, even cardiac dysfunctions by hemochromatosis. So one has to be careful here, but estimating ferritin and T-sets is a must in all heart HFrEF patients. And they do benefit in terms of symptoms. So it is earned class 2A value today for their use.
We'll have last question from Dr.
From the Noida Center. There is something from the Noida Center.
Yeah, carry on. Noida Center, please.
Yes, Dr. Gulab Gupta would like to ask something.
Dr. Subhash?
Yes, Dr. Gulab, please.
Yes. Sir, if potassium is high, it may be 5.9 or 6. We can continue all the drugs along with potassium lowering drugs. Will it be beneficial? Because we don't want to deprive of these 4 pillars.
That's a good suggestion.
The potassium lowering drug along with all this.
So until a value of 5.5, you could comfortably continue with both ARNI and MRA. However, if it is in excess, then the first move should be to de-escalate one of them. Maybe you can withdraw MRA for time being and reassess. But giving a K-bind along with these 2 drugs would not be a good idea. So I would reserve K-bind for a very, very niche special cases of advanced hyperkalemia, but not otherwise. So the first step is to withdraw one of them. It adds to the cost also.
Thank you very much, Professor.
Now, Rohtak. I think so. There is a query from Rohtak.
Okay, last question. Last question, please.
Yeah, we are.
So I have a question to Dr. Chandra. There's a patient 8 months back with congestive cardiac failure, and it was post-viral fever. Young person, 25-year-old, and he was treated with all these four modalities, not SGLT2, diuretic, MRA, beta blocker, and ARNI. And the patient has settled very nicely. He was subjected for an coronary angiography as well, which did not show any major atherosclerosis or blockade. He is presently on 200 milligram ARNI twice a day, 10 milligram bisoprolol, and spironolactone. And he's doing wonderfully well, and his EF has improved to around 45%. The thing is very young, and as you said, and as we understand that the drugs have to be continued for almost indefinite period. So, any margin of relaxing the doses and trying to see the situation with reduced doses, because a young person and he has to take drugs for almost 50 years or 60 years, whatever life he has.
So that's a very good question, sir. I must say at the outset that there's a trial called as TRADE-HF, which says that in all HFrEF patients, if these four foundational therapies and addition of CRT has improved ejection fraction, you must continue these therapies at the same pace. The exceptions would only be a postpartum cardiomyopathy where a lady delivered a baby, had poor ejection fraction, and then it starts improving. Or a post-COVID cardiomyopathy. In COVID, we have seen a lot of cardiomyopathies where COVID has been cured and now. And the third could be this subset where a young boy who had a myocarditis and now ejection fraction has improved. There could be a case here for de-escalation or holding therapies for some time and then seeing what the ejection fraction is impacted. So these are three exceptions, but otherwise in a regular day-to-day patient of HFrEF, one must continue these therapies. We have instances where CRTs were replaced after their batteries exhausted at the end of 10 years or 12 years. These patients were given another CRT so as to see that the ejection fraction is robust and this can save you of lot. There could be an exception, AICD. If ejection fraction improved beyond 35%, one must stop looking at AICD because the chances of sudden cardiac death are much less here. But otherwise, one has to continue with all the therapies.
So another point I want to say is regarding FCM, that using 500 milligram infusion at a weekly or something is better than giving 1 gram
Iron. So the standard dose of iron is 1 gram as a bolus. Yeah. And 500, I'm not sure whether they were used in trials. It's usually 1 gram followed by 3 months estimation or repeat injection, and then every 6 months or 1 year one can estimate.
So FCM can be given 500 after 1 week, again 500 can be given, or it can be given 1 gram.
That is what in fact I was listening to a lecture by Dr. K.K. Sethi in Delhi, and he was recommended, and even in personal experience what I have seen is that using 500 milligram more, say 1 gram, most of the patients will have some kind of a reaction, some rashes, some other thing. 500 milligram infusions are very safe.
All right. Thank you, sir.
Thank you very much for your participation from various centers. Thank you, Subhash Chandra, for excellent deliberation on the hardware. Please give him a big hand.
Well, thank you, Dr. Subhash Chandra, and it is my pleasure and privilege to request the chairpersons to please present a memento to him. I'll request Dr. S.P. Kalra, Senior API member, please, sir, to present a memento to the chairpersons.
लेडीज
सर ये मैम पहले मैम को दे दीजिए सर. Well, with the felicitation, we move on to the next session. which is on rheumatoid arthritis, and the chairpersons for the session are Dr. M.P.S. Chawla, Dr. Atul Kakkar, Dr. Ghanshyam Pangti. Dr. Rohini Anda is available online, and we have his recorded lecture. Yes.
So now we move on to the next topic, rheumatoid arthritis, do's and don'ts in 2025. And we have an accomplished speaker, Dr. Rohini Handa, with us, who's going to throw light on this. And it is always a pleasure to listen to Dr. Rohini Handa, who's an excellent clinician and very good human being. So over to you, Dr. Rohini, please.
Well, friends and colleagues, I'm unable to join you in person, and I have my recording, which is there, and I'm available online to take up the questions.
Ladies and gentlemen, let me begin by wishing you and your families a very happy, joyous, and productive new year. Let me get started by sharing my screen. My brief this evening is to talk about rheumatoid arthritis, key do's and don'ts in 2025. Rheumatoid arthritis is the commonest inflammatory polyarthritis encountered in clinical practice, and the key do in 2025 is learning to recognize patterns. The diagnosis of rheumatoid arthritis is clinical. Serology can help guide you, but not decide for you. Examination of the hand holds the clue, and rheumatoid arthritis is a diagnosis made on the bedside when a patient presents with bilateral symmetrical inflammatory polyarthritis involving the small joints of the hand and feet with a duration in excess of 6 weeks. And as you can appreciate, there is symmetrical involvement of the PIP joints, the MP joints. Almost 20% of the patients are seronegative, and the only way of diagnosing seronegative rheumatoid arthritis is clinical examination. We do have classification criteria for rheumatoid arthritis proposed nearly 15 years ago, where you have a scoring system, but I would like to remind you that these are criteria for classification, not for diagnosis. The diagnosis continues to be clinical, and there is a trade-off when you talk of classification versus criteria for diagnosis. Classification criteria are meant to be specific, whereas criteria for diagnosis are meant to be applied to individuals and are meant to be sensitive. There are some caveats in the diagnosis of rheumatoid arthritis. One should be extremely reluctant to diagnose rheumatoid arthritis unless the small joints of the hands are affected. Single joint involvement, one should be reluctant to harbor a diagnosis of rheumatoid arthritis. DIP joint involvement is distinctly uncommon, and low back pain is uncommon in rheumatoid arthritis. Unrelated causes, certainly yes. Patients of rheumatoid arthritis can get Heberder nodes, Bouchard nodes. Asymmetrical involvement should make you think of psoriatic arthritis and spondyloarthritis. What about rheumatoid factor? This is a test which is widely ordered and equally widely misinterpreted. Several conditions other than rheumatoid arthritis can give rise to RF positivity. Immunoinflammatory conditions like lupus, Sjogren's, all of which can give rise to RF positivity. 5% of healthy elderly individuals would be RF positive. Infections can trigger RF positivity, and conditions like sarcoidosis, idiopathic interstitial fibrosis can be associated with a positive rheumatoid factor. And this is the reason that it is called the rheumatoid factor and not the RA factor. Antibodies other than rheumatoid factor, anti-CCP antibodies are widely employed, and I would like to point out that their sensitivity is no more than rheumatoid factor. Where they score over rheumatoid factor is their higher specificity. So you can get 4 serologic subsets of rheumatoid arthritis: double positive, you could have single positive, either RF or CCP, and the other is negative, or double negative. These serologic subsets do not influence treatment. And let me share with you this case vignette. This is the story of a young male who presented with right wrist pain. His GP ordered a rheumatoid factor, was positive, was started on low-dose steroids and hydroxychloroquine, did not improve. This is his X-ray, and you can see a couple crowding here. And this is a biopsy that was done, and you can appreciate necrotizing granulomas. So this was tuberculosis of the wrist masquerading as rheumatoid arthritis. And if you go over the history, it was a single joint involvement of the wrist. And in one of the don'ts was considering a diagnosis of rheumatoid in a patient with single joint involvement. And the teaching learning point is joint pains with rheumatoid factor positivity do not make up a diagnosis of rheumatoid arthritis. Clinical correlation is a must. At this point, I would like to iterate that 3 things go into the making of a diagnosis in rheumatology: history, examination, and investigations. And the font size is a reflector of the importance of each of these. One should be extravagant with eliciting history, be generous when it comes to examination, examine the patient thoroughly, and be parsimonious when you talk about investigation. And as Osler said, listen to the patient. He's telling you the diagnosis. And we in rheumatology focus on pattern recognition. And this is a simple example. These are striped animals, and there are no prizes for guessing that this is a tiger and this is a zebra. Much in the same way, rheumatologists identify patterns. These are some examples. Typical pattern of rheumatoid arthritis: symmetrical involvement of the small joints. It's a boggy swelling. Unlike osteoarthritis, where the swelling is bony, the DIP joints can be involved in osteoarthritis. And as I mentioned, 5% of the healthy elderly are rheumatoid factor positive. So rheumatoid factor does not mean rheumatoid arthritis. This is an example of a bony swelling. So when you palpate your joints, you can appreciate it is bony, and the swelling in osteoarthritis is bony, whereas in rheumatoid arthritis, you get a boggy feel and you know that it is synovitis. Psoriatic arthritis, pleomorphic presentation, can be asymmetrical, can be symmetrical, and this is one which involves the spine as well. The DIP joints can be involved, and you have the additional domain of the skin, the nails, tendinous involvement, enthesitis, and dactylitis, and these are some examples. So as you can see, the entire thumb is swollen. This is dactylitis, and these are two patients with thumb dactylitis, and this is a giveaway that the patient is having psoriatic arthritis, and you can appreciate the nail changes also. This is another example of psoriasis with dactylitis and nail changes, and yet another example. Dactylitis is seen in psoriasis, also spondyloarthritis, and in dactylitis, the entire digit is swollen. It's called a sausage digit. In contradistinction, in rheumatoid arthritis, you have a fusiform swelling, plump in the middle, slender at the sides. And once you look at this, the pattern recognition is easy. Lupus, it is a picture that mimics rheumatoid arthritis in terms of joint involvement, but with the additional features of fever, photodistributed rash, oral ulcers, and hair loss. The arthritis is correctable, and Jacob's arthritis, the most important cause is nowadays not rheumatic fever, but lupus. So when you talk about rheumatoid arthritis diagnosis, what you ought to do is recognize patterns, and what you ought to avoid is serologic interpretation in isolation. Talking of diagnosis, the key do is pattern recognition, and the key don'ts are failing to consider a diagnosis of rheumatoid arthritis when rheumatoid factor is absent. You are likely to miss seronegative rheumatoid. Basing a diagnosis of rheumatoid arthritis on serology in isolation without clinical correlation. Attributing importance to borderline serologic abnormalities. Frequent repeating of rheumatoid factor is a big no, and ordering anti-CCPs without ordering a basic rheumatoid factor is a big no. Having talked about diagnosis, let me now talk about treatment and what are the key do's in 2025. The key do is measurement of disease activity and titration of treatment according to disease activity. The emphasis on the fact that methotrexate continues to be the anchor drug. Corticosteroids used judiciously are invaluable, and you need to select your patients carefully for targeted treatments. The concepts in rheumatoid arthritis have changed dramatically. This is the 20th letter of the English alphabet, and we now talk about the 6 T's of rheumatoid arthritis: time to treat, treat to target, and last but not the least, the targeted treatments. Time to treat. Rheumatoid arthritis is a time-critical illness. Early treatment fetches you the best evidence. You treat to target, and the target is ideally remission, failing which low disease activity, and targeted treatments are the biologicals and the JAK inhibitors. Let me spend a moment talking about measurement of disease activity. Rheumatoid arthritis is a multidimensional disease. You have different facets: disease activity, disability, structural damage, and this is akin to the different dimensions of diabetes. Just like you mentioned the sugar levels, you look at HbA1c, then you look at organ damage, retinopathy, neuropathy, nephropathy. Much in the same way in rheumatoid arthritis, you look at disease activity different from disability, and you also look at structural damage using X-rays, and then figuring prominently in all rheumatic diseases is quality of life, and you have validated measures for all these. And in rheumatoid arthritis, you count the number of joints, assess how many are swollen, how many are tender, and you have these disease indices which are now routinely employed in clinical practice. Paucity of time precludes me from going into the details. And then you have these cutoffs available which define whether a patient is in low disease activity or moderate disease activity or high disease activity. Having talked about the fact that we need to measure disease activity, we need to treat to target, and for defining target, we need to measure disease activity. What are the tools of the trade that are now available to a clinician? We have anti-inflammatory drugs, useful for abrogation of inflammation, but the mainstay of treatment are the disease-modifying drugs and the targeted treatments with glucocorticoids used when necessary. Synthetic DMARDs, the conventional synthetic DMARDs, current treatment focuses around hydroxychloroquine, sulfasalazine, leflunomide, and methotrexate. Methotrexate is the numero uno in rheumatoid arthritis. What has changed is not the drug. What has changed is the way that we use the drug. The starting dose of methotrexate is 15 milligrams per week. Rapid escalation to the point of disease control or tolerance. You build up to 25 or 30 milligrams per week. And if the patient is requiring more than 15 milligrams per week, you switch to parenteral methotrexate, subcutaneous or sometimes intramuscular. And if the patient wants an oral dose, you split it into two on the same day. So if the patient is taking 25 milligrams on a Sunday, you give 15 in the morning and 10 at night after meals. And by splitting, you ensure better absorption. A point of debate, monotherapy or triple therapy. And the answer is not all patients require triple therapy. Optimally used methotrexate enables you to achieve low disease activity in 30 to 40% of the patients. So you start with a single drug, build up rapidly. Should there be suboptimal response, you add hydroxychloroquine or leflunomide. The gains with double or triple therapy are modest, and more people are starting with a single drug and then adding on. In the past, there were some votaries of starting with 3 drugs from the word go. Actually, it doesn't matter. What matters is disease control. The means do not matter, the end matters. And unlike probity in public life, where means are as important as the end. Now, this drug that was once called the panacea for rheumatoid arthritis, the Pudia story, glucocorticoids, indiscriminate use, and this is, all of us are familiar with this scenario. Injudicious use of glucocorticoids. In rheumatoid arthritis, you talk about use in early disease, use in established disease. Early disease is a disease duration less than 6 months, and you use it as a bridge therapy where you use it low dose, 5 to 10 milligrams for 4 to 6 weeks to bridge the gap between institution of disease modifying drugs and the onset of action. Established disease, where the disease is more than 6 months old, you use it for a different rationale. You use it to tackle acute exacerbations of disease, when a woman is contemplating pregnancy, when you have a difficult to treat rheumatoid arthritis, extra-articular rheumatoid with interstitial lung disease or vasculitis, and late onset rheumatoid, onset above the age of 60 or 65, where glucocorticoids are very useful. And these are some examples. This is rheumatoid vasculitis, digital gangrene, wrist drop. And here in this scenario, you would use glucocorticoids. Rheumatoid with scleritis, scleral melt, pyoderma gangrenosum, rheumatoid with interstitial lung disease, where glucocorticoids are used. If you have a single joint that refuses to calm down, you inject it with glucocorticoids rather than escalating systemic treatment. Having made the point that methotrexate is the number one drug, we now move away from serendipity to specificity, and I'm talking of the targeted treatments, of which two varieties exist, biologicals and the targeted synthetic DMARDs. Biologicals have taken the world of rheumatology actually to a level where you talk about durable remission, and they have made a tremendous difference to the quality of life of patients with inflammatory arthritis. You can target different agents, the cytokines, the receptors, the cells, and the intracellular pathways, and you have a plethora of agents that are available. The ones checkmarked in green are available in our country. But a question that is commonly asked is, what do biologicals achieve in rheumatoid arthritis? Are they expensive painkillers? And the answer is, not only do they reduce signs and symptoms and improve physical function, they retard radiologic progression. In fact, when we were students, we were told erosions do not heal, and the biologicals have proven that erosion in rheumatoid can indeed heal. And this is how they differ from the traditional synthetic DMARDs. And in the targeted treatments, apart from biologicals, we have JAK inhibitors. Two are available in our country, and tofacitinib is the phase which launched several molecules widely used, equally widely misused in our country, and notwithstanding anything, tofacitinib has not replaced methotrexate as the number one drug. Methotrexate is the DMARD of choice in rheumatoid arthritis, unless there are cogent reasons not to use that. So when are targeted treatments used? When you have suboptimal response or intolerance to the conventional synthetic DMARDs. At this point, before I end, let me emphasize one thing. Commonly asked questions, are JAK inhibitors biologicals? And the answer is no. They are chemically synthesized drugs, not biologicals. Do they replace methotrexate? And the answer is an emphatic no. Are they first-line drugs? Answer is no. Can you use them without screening for Hep B, C, or latent TB? Answer is all targeted treatments, biologicals or JAK inhibitors. You need to screen your patients first. Can tofacitinib be combined with biologicals? And the answer is no, for the fear of profound immunosuppression. Given the fact that we are now spoiled for choice, we have a problem of plenty in rheumatoid arthritis. We have the conventional synthetic DMARDs, we have biologicals, we have the targeted synthetic DMARDs. How should a clinician sequence these drugs? And this is a pragmatic sequencing. Start with methotrexate, optimally used. Suboptimal response, combine it with hydroxychloroquine or leflunomide. Suboptimal response, use JAK inhibitors in combination with methotrexate or alone. And if there is suboptimal response, you can graduate to biologicals. And of course, you need to individualize your treatment. In our country, the biologicals usage is much less because of the cost associated with the use of biologicals. What should you not do? Repeating rheumatoid factor at every visit. Disappearance of rheumatoid factor is not the goal of treatment. And then you have that situation, people get panels of tests done and they carry a report of RF positivity, have no clinical disease whatsoever, and such patients who are clinically quiet but serologically active need observation, not intervention. What is a big don't? Disdain for common questions posed by the patient on diet, exercise, other systems of medicine. We should be sensitive to their beliefs. We should not make fun of their beliefs and should answer their questions on alternate systems of medicine, diet, exercise. What might seem trivial to a doctor is extremely important for the patient, and the patient does not care how much you know unless he knows how much you care. Ladies and gentlemen, I would like to end by mentioning that the key do's in 2025 are learning to recognize patterns, measuring disease activity, and titrating treatment according to the disease activity. You learn to extract the maximum out of methotrexate and use steroids and targeted treatments judiciously. It's a nuanced approach to the disease that is rheumatoid arthritis. Thank you very much for your kind attention.
Thank you, Dr. Handa. Excellent lecture. And you made it sound so simple. But since you mentioned that the JAK inhibitors basically are abused, so could you just elaborate when should we use JAK inhibitors and what are the precautions we should take?
Thank you very much. And my apologies that I could not be there in person. JAK inhibitors somehow are thought as the answer to all rheumatic diseases. And the answer is they are second line drugs. It's only patients who show suboptimal response to optimally used methotrexate that you should consider JAK inhibitors. The second situation is intolerance to the conventional synthetic DMARDs. You have ladies who complain of hyperpigmentation with hydroxychloroquine, have nausea or anticipatory emesis with methotrexate. That's the situation where you would, substitute the conventional synthetic DMARDs with tofacitinib. And then, of course, if you have a bad rheumatoid, you can combine it with methotrexate, but you need to screen your patients with hepatitis B, hepatitis C, and also latent tuberculosis.
So the screening is same as that for biologicals. It's the same.
Absolutely. I mean, the screening remains the same, although I may have a difference of opinion on this, but if methotrexate were to be introduced today, you would have the same screening. So I may have a difference of opinion on who needs screening for what, because in a country endemic for tuberculosis, the screening adds to the cost. But guidelines being guidelines and recommendations being recommendations. But I'd like to listen to what Dr. Chawla has to say. He's a veteran clinician.
One thing is that, as they have rightly said, but JAK inhibitors specifically, for example, they have risk of GI perforation. So probably in cases they have diverticulitis or GI symptoms, I would be careful, using them. Other, if there is an elevated cardiac risk, rheumatoid arthritis, there is a persistent chronic inflammation. So they have been found to be associated with, raising lipid levels, and then you have these clots and these problems. So you'll be careful. So one thing I think I definitely agree with you, methotrexate remains the drug of choice. But I have seen in certain cases before moving on to, you start with oral. Some patients that don't, respond to oral. Then I have tried injectable. Have you got any experience? Many patients, they will, respond to injectable methotrexate.
Absolutely. Before you call it quits with methotrexate, you must learn to extract the maximum. And subcut methotrexate or even intramuscular methotrexate can do the drug trick when oral methotrexate has failed. And then drugs work only if patients take them. You tell the lady 2 doses on Sunday, 15 in the morning, 10 in the evening, and she's only taking 1. and you give her an injection and you find that it doesn't, it starts working. There is a caveat with tofacitinib also, the risk of herpes zoster. And the risk of herpes zoster is much more with tofacitinib. And if you have an elderly person with a comorbid condition of coronary artery disease, one should be very circumspect. It's ankylosing spondylitis, the young people, where one could be a little carefree. So the cardiovascular side effects of tofacitinib are well known. Then I have some questions in the chat box. With the permission of the chair, can I answer that?
Please go ahead, sir. Please go ahead.
This is a question from Gurgaon. Patient on methotrexate and JAK inhibitors has chikungunya. Can we continue these drugs? Ideally, in face of an infection, you can temporarily withdraw your disease modifying drugs. Whether it is a chest infection or chikungunya, you tackle the infection first. That is the proximate risk. Rheumatoid is distant. Should the patient have post-chikungunya arthritis, methotrexate can be used in those situations. And the distinguishing line between post-chikungunya arthritis and seronegative rheumatoid arthritis is rather subtle, where one ends and the other begins. And as I always say, जो ठीक हो गया चिकनगुनिया, जो बच गया वो rheumatoid. But in face of infection, the proximate thing gets precedence, whether it is typhoid, whether it is chest infection. The second question from Vijay Arora Center, East Delhi. At what score should the treatment be started with methotrexate? Let me go on record to say that most clinicians eyeball. They would get an idea of the joints, would not put it into an app. The younger people would always put it on an app. After eyeballing, it's not that unless you have a very, very mild rheumatoid, one would use methotrexate for everyone. It is the de facto standard of care for rheumatoid arthritis. The scores mention disease activity and activity changes. बीमारी की फितरत नहीं बदलती. So rheumatoid is a different disease at different times of time frames that you see the patient. So scores are not that when you have a high activity, you would use methotrexate, and when the activity is low, you will reduce the dose of methotrexate. So if you have achieved control with 20 milligram, you can de-escalate your treatment, and the treatment is divided into phases. Contain quickly, maintain for long periods of time, and then de-escalate gradually. So the scores do not dictate methotrexate. It's hydroxychloroquine as the only drug is used only in what people call the community rheumatoid, mild rheumatoid, very minimal kind of rheumatoid factor elevations, no poor prognostic factors. Then there is a question from Gurgaon. The colleagues would like to know rise in...
Sir, Dr. Paras, this slide, just wanted to complete the query to the previous question. If this young female, age group 40, has 1 or 2 joints flaring off and on, going into remission for say 1.5 to 2 months, then again joint pain for say 2 to 3 weeks, do we delay the methotrexate? Do we harm the patient by delaying the methotrexate for a year or so?
Absolutely. The fire continues to smolder inside. There is nothing like a burnt out rheumatoid. You would just reduce methotrexate to 7.5. But 1 to 2 flares will give rise to cumulative damage. If she begins at 40, by the time she is 60, inflammation into time equals damage. That is the classical principle of rheumatoid arthritis. So if she has grumbling 1 to 2 joints, which resurface every 2 months, that would be rated as active rheumatoid arthritis, and one would use methotrexate. Once you achieve control, even 5 milligrams of methotrexate a week can be used. So you may start with 15 milligrams, but a maintenance dose could be as low as 5 milligrams a week.
Thank you, sir. I think most of the queries you have solved, and it was a masterly lecture and masterly
One
slides.
question I would like, there are two
Yes, sir.
questions, if you permit me 2 minutes.
Yes,
Rise
sir.
in anti-CCP, the levels of serology do not govern treatment. Iguratimod, the lineage of iguratimod is questionable. Some people say it's a painkiller, some people say it's a disease modifying drug. The data on iguratimod disease modification is not robust, which is why it's not available in the West. Monitoring methotrexate levels, actually, practically speaking, no. But in times to come, therapeutic drug monitoring, even for biologicals, is making a foray. Maximum dose of methotrexate before we add JAK inhibitors, it's actually 25 milligrams or a point of tolerance. Any difference in response to oral versus subcut? Dr. Chavla has shared his insights. Subcut is superior to oral. And different diagnosis, differential diagnosis well taken from webinar 4. You need to consider sarcoid, etc. Very well taken. And if methotrexate is not tolerated, is leflunomide good? Yes. If you have intolerance, you can use leflunomide. What is the longest duration of methotrexate in my practice? About 25 to 30 years. When I was a resident, they came to AIMS. They are called legacy patients and they do so very well. And legacy patients are with everyone. एक एंगस्पॉन्ड है, 2 गोली सल्फाथैलाजीन खा के चलता जा रहा. So legacy patients are with everyone. So that's about it. Thank you very much.
Sir, one question I will ask, just small question. You use the term flare, sir, rheumatoid flare. So is there a difference between rheumatoid flare versus a relapse? And we have such a great rheumatologist. Why we are still sticking with the classification criteria? Why don't we come up with a diagnostic criteria? So many associations and so many have been developed.
There are 2 questions.
Yes, sir.
Disease flare, exacerbation, or relapse is all a matter of semantics. So when you say relapse, it means that the quiet disease has become active. And whenever you have a chronic disease becoming active, that's called a relapse. You may call it a disease flare. You may call it an exacerbation. It actually does not matter. Then criteria for diagnosis. And the people who make the classification criteria, the pundits, their gold standard is the recent judgment of a seasoned clinician. And on a cold wintry day, I see all seasoned clinicians here. So, which is why they say the diagnostic criteria is physician judgment. That is called the gold standard. And people like Vijay Arora, Dr. Makkad, I can see their other colleagues. So मरीज हाथ से निकालते हैं. So nothing replaces the judgment of a seasoned clinician. Ghanshyam is laughing. I mean, people who see, that is why we have all classification criteria, and they say the classification criteria are subservient to clinical judgment. And that is why you do not have criteria for diagnosis, which continues to be physician judgment.
I think it is always, great pleasure listening to you. And I'll recommend all of you, if you have an interest in rheumatology, please go through Clinical Rheumatology, book published by Dr. Rohini Handa. So with this, we come to the end of this. Thank you.
Well, thank you, sir. Thank you, Professor Handa from Chandigarh. He is the 11th satellite center that we have. And his memento we will deliver once he is back from Chandigarh. Thank you, Dr. Handa, sir. And I request Dr. Sandeep Garg, Treasurer, AP Delhi chapter, to please felicitate the chairpersons.
वो ग्रुप सारे सेंटर्स बच्चे और होंगे नहीं तो होंगे.
Well, it is my pleasant duty to invite the chairperson for the next session, Dr. Atul Gupta, Senior Physician, Northern Railway Hospital, and Dr. Rupali Malik from VMMC. I request both of them to come on stage and share the final session. In fact, before we began today, there was somebody was commenting upon, Anupam, you should not commit spelling mistakes. So I think Dr. Upadhyay will correct that spelling mistakes, NASH and MASH.
this is the last session of today. That's on management of MASLD
Is there a
or
point?
MASH. None other than Dr. Rajesh Upadhyay, who is the leading practitioner gastroenterologist from the North Delhi. And he has been a known figure for all of us. He has been instrumental in the multiple conferences in API. And recently we had our EPICON 2024, which was his brainchild, and it was one of the finest conference in the memory of mine. So, stage is yours, Dr. Rajesh Upadhyay.
Thank you very much. And good evening to everyone. Giving a lecture last thing at night at about 9:30 can be very dicey. But I'm glad people are still here. And I'm going to talk about MASLD and MASH, which is one of the biggest silent epidemics engulfing this globe. Now, before I come to the details of the epidemic and how to manage the disease, let me start with the terminology itself, because it's a new terminology. And the new terminology came from the previous terminology, which was NAFLD. So why the change in terminology? Because NAFLD was saying non-alcoholic. It was not specifying the cause of the problem, but saying it is not alcoholic. And alcoholic in any case has got a stigmatization. And so does fatty liver. Because when you say fatty, it implies sort of lazy or something. So the term which was agreed upon by a large number of people, the gastroenterologists, was steatosis. So NAFLD became MASLD. MASLD is metabolic associated steatotic liver disease. And what it means is that there is steatosis of fat in the liver and at least one cardiometabolic risk factor. And you know all the cardiometabolic risk factors: elevated triglycerides, low HDL, diabetes, pre-diabetes, obesity, high blood pressure. Now, does it mean that the NAFLD has completely changed the disease itself? No. MASLD and NAFLD can practically be used interchangeably, because in India, the MASLD population almost entirely overlaps what was previously defined as NAFLD. So there is a precision in terminology, but no change in the real population which we are dealing with. And MASH came from NASH. It was non-alcoholic steatohepatitis, and MASH has become now metabolic. So the key problem and the key pathogenic issue in this condition is metabolic. So this was the outcome of what was called the Delphi consensus, where the terminologies came in. And you can see on the left-hand side that metabolic associated steatotic liver disease, or MASLD, and MASH are there. But people realized that a large number of people with metabolic dysfunction or conditions like diabetes, hypertension, etc., are also taking alcohol. So where do you place them? So MASLD and increased alcohol intake was called MET-ALD. MET for metabolic and ALD for alcoholic liver disease. And you can see amongst this, there could be MASLD predominant or ALD predominant. So depending on the degree of metabolic factors and the quantity of alcohol which is being consumed. So that is given over here. Then liver steatosis can be due to alcohol, which we all know, and that became alcohol associated or alcohol related liver disease. And then there are specific other etiologies for steatotic liver disease, and one has to take a very good history to find out whether the patient is taking certain drugs which can cause, or do investigations in order to find out whether they have hepatitis B infection, C infection, or other conditions. And if you're unable to put any the disease or the steatosis in any of these conditions, it is classified as cryptogenic steatotic liver disease. Now, as I said, this is one of the world's largest silent epidemics. And you can see on this map, the red areas are the ones where the prevalence has gone above 40%. Above 40%, on the other hand, most of the nations globally now are reporting more than 30%. So almost 1/3 of the global population has got this MASLD. And if you look at the high-risk groups, for example, the diabetics or the obese, the prevalence is almost doubled. So 60 to 70% of diabetics worldwide will have the steatotic liver disease or fatty liver disease or MASLD. So this is something which is very worrying, and we need to act, and we need to act now. So this is, I'm showing you a study which was done in Delhi, and what it found when they looked at about more than 6,000 individuals was the prevalence of MASLD in Delhi was 56.4, or let's say 60%. So is it surprising? I don't think it is surprising to many of us. We see how commonly our ultrasound reports are mentioning about fatty liver disease, no matter what we've sent the patient to the ultrasound room for. The other important thing is that amongst the overweight or the obese in this city, almost 90% had MASLD. 90%. And I was surprised because we were conducting a study in our own hospital. Yes, this was hospital-based, but amongst the diabetics, prevalence of MASLD was 92%, and prevalence of NASH was 50%. So that again became very worrying. The longer the duration of diabetes, the higher the prevalence of NASH. Now, this is the natural progression of the disease. And on the left side, you see a normal liver, which gets laden with fat. And the fat is mainly coming from three sources. One is the adipose tissue, and the other is the dietary fat. And another very important is the de novo lipogenesis, which is occurring inside the liver itself. So three sources, and they bring about an inflammatory cascade, producing the MASH or the inflammation inside the liver, which is also influenced by certain modifiers. And we know that genetics and intestinal microbiota play a very important role in this. So then we have NASH, and once we have NASH, there is a fairly high prevalence of fibrosis. 20 to 40% of the NASH in general population also will develop fibrosis over a period of time, and 20 to 30% of patients with fibrosis will go on to develop cirrhosis of the liver. 5% will develop hepatocellular carcinoma, and the liver has been really ravaged. Now, this is a slide which I want to show because you're dealing with so many diabetics. The progression of NAFLD or MASLD to cirrhosis and associated mortality is much higher in diabetics as compared to the general population. And above is shown those individuals who are not diabetics. And if you look below, everything has practically doubled. So what I am worried about is, I believe the number of diabetics in this country at the moment is about 100 million. Am I correct? I think it is about 100 million. 200 million. 100. Okay. 20%, if we say, let's say 50% of them or 60% of them will have fatty liver or MASLD, which makes it around more than 100 million. And of that, even if subsequently over a period of 10 to 15 years, the 20% develop cirrhosis, we are looking at an amazing number. How are you going to manage such patients? And therefore, it is very important to catch the problem early and treat it. So MASLD fact sheet, now it is the most common liver disease, second most common reason for liver transplant, but the leading indication for transplant in people under the age of 50, leading predisposing factor for primary liver cancer. And majority of people, and this is one thing because this is a myth, majority of people with MASLD have normal liver enzymes. And one of the things which we see is normal liver enzymes, tiki hai, everybody has a little bit of fatty liver, so it's all right. I think this is where we are erring. Let anybody with any degree of fatty liver must be further evaluated for severity of the problem. And the question you will ask is, but why reduce fatty liver? Because people do sometimes say that ye to sab mein hota hai, so why treat or start doing investigations? I sent the patient for abdominal pain and now he has come back and he's talking about his liver. Well, the reason is, and this is a very interesting study in Korea, 2 million Koreans followed up from 2009 to 2013, and their fatty liver index was measured. What is fatty liver index? It is an index which has 4 parameters: body mass index, which is BMI, waist circumference, triglyceride, and gamma GT, and that tells us the likelihood of the person to develop fatty liver. And what was found, that those who developed new fatty liver, the diabetes development was almost twofold in such patients. And this is something which I have been talking about for many years, that liver is the origin of diabetes. Anyway, it is both ways, I understand. But this is showing that if you have fatty liver, your likelihood of developing diabetes increases at least twofold. And look at the other aspects. The heart attack, 13% more, stroke, 17% more, and death, 46% more. Now, during the study, in those where fatty liver persisted, heart attack went up further, 23%, stroke again 23%, and death increased further, 64% more deaths. Whereas in those patients where the fatty liver regressed, death was reduced by 17%. So that is a very clear indication that we need to do something about this and reduce the fat. Now, it is interesting that in MASLD, the most common cause of death is cardiovascular disease and not liver disease. And if you look at the right-hand side, 42% of the patients die because of cardiovascular disease. 18% die because of liver-related disease. And there is another data which has come, that females are more prone to developing cirrhosis as compared to males. And 18% deaths are due to malignancy. And it's not only the hepatocellular carcinoma, but a whole load of other malignancies. And males are more prone to develop the malignancies. So, which particular point is the most dangerous where the disease worsens? Because yes, fat has to be reduced. undoubtedly. But where is our critical point? And the study showed that the higher the fibrosis, the higher is the mortality. And I'll show this in a different graph fashion. This on the left-hand side is the risk of severe liver disease. On the right-hand side is liver-related mortality. So risk of severe liver disease, you will find increases exponentially after F2 stage. And that F3, F4 goes up sky high. Similarly, liver-related mortality after F2 stage goes high. And exponentially high, not high. So it is important that we try and diagnose early, treat early, so that progressive liver disease, does not happen. So who should we screen? And recommendations have come from various guidelines. Those who are obese, type 2 diabetics, pre-diabetics, especially those with elevated enzymes, hypertriglyceridemia, low HDL, hypertension, and the last one is also very important, relatives of patients with severe fibrosis or cirrhosis. And this is the genetics which is playing a role. If there is a person within the family who has got, NASH-related cirrhosis, there is a higher risk for the other members in the family. So decision support tool, steatotic liver disease, and you have to assess whether the patient meets the cardiometabolic criteria. If yes, only one thing one needs to answer is there any other cause for steatosis? And you just have to take a good history and probably do some of the basic tests like hepatitis B, hepatitis C, and you are sure. And a diagnosis of MASLD can be made easily. On the other hand, on the right-hand side, if there are no cardiometabolic criteria, then you have to find whether there are other causes. And as I said, you do investigations. If you're not able to find, then it is cryptogenic steatotic liver disease. And if you're able to find, then you will identify specific diseases. Now, it has always been said that liver biopsy is the gold standard for diagnosis. I would say that this is the imperfect gold standard because there are, a number of limitations of liver biopsy also, which I have showed in this slide. But most important line is the one in the bottom. It is impractical for population screening. It is very difficult to convince patients to come for biopsy. And therefore, the center stage of diagnosis has now been taken over by non-invasive tests to risk stratify liver fibrosis. And on the left-hand side, the simple ones are FIB4 and the APRI and the NAFLD fibrosis score, of which the most commonly used in our country and many other countries is FIB4, which takes into account only 4 things: the AST of the patient, the ALT of the patient, the platelet, and the age. And you don't have to do any calculation. You can just put the findings on a smartphone app and it will give you a reading. Others are shown on the right hand, on the middle side, which is not used very frequently in India because it is not easily available. But the one on the right side is most important after the simple scoring, and that is the elastography. And we know that transient elastography, the vibration control, is the most validated method of assessing the liver stiffness. 2D shear wave elastography is also there, and MRI elastography is very accurate, but it is very costly and it is not easily available. So once you have found that the patient has got fatty liver, the next step obviously is the FIB4 testing. And I have given the values right in the middle there. FIB4 less than 1.3 shows low risk. And you don't have to worry too much except the lifestyle changes and repeat the FIB4 after a year or two. On the right-hand side, if the FIB4 score is more than 2.6, that means it is a severe disease And normally, although it is not recommended, but normally we also do a fibroscan on such patients. So when we do the fibroscan, then the patients can be classified into 3 criteria. The most important group for doing the fibroscan is the intermediate one, which is the one between 1.3 and 2.6. LSM less than 8 kPa is mild disease, 8 to 12 intermediate, and the ones which are above 12 or 13 are high risk. So do we never do liver biopsy? The answer is no, we do liver biopsy, but when? When there is a risk of advanced fibrosis and we are not able to make up our mind on the basis of the non-invasive testing, yes. Where other etiologies cannot be excluded without liver biopsy. And there is one very important group, which you all must have seen, persistently elevated liver enzymes, despite whatever treatment you are giving. I think they must undergo liver fibrosis. So I'll come to the main thing about the management now. And management, the most important thing I would mention is it should be patient-centered. Each patient can be different, and I'll tell you and I'll show you how they are different. First is, we know that obesity is very common, so tackle obesity and overweight. And remember, there are dietary modifiers, the cofactors. What? Stop alcohol, stop smoking. Fructose can be deadly because glucose is utilized by the entire body in the metabolism, but fructose only goes to the liver and is metabolized in the liver. And there are many other factors where fructose ends up with the production of fat inside the liver. So cut down on fructose. And coffee is good for liver. In fact, it is said that 3 cups or more of coffee per day may be beneficial in such patients. The other thing is, don't forget the comorbidities. The disease is lifestyle and metabolic. So what are the metabolic abnormalities? You have to treat them appropriately. Obesity, diabetes, dyslipidemia, hypertension, all need to be treated. And I think if I would not be doing justice if I don't talk about the lifestyle modification. That is the key intervention which we all must be spending a little time with our patients, telling them about the exercise, aerobic exercise, 150 to 300 minutes per week, moderate intensity, or lesser if they are of high intensity. Resistance training, 45 minutes per day, at least for 3 days a week. So all these are important. And there are a number of dietary concepts, but it is I would say, complicated that if I get into this, it can be a full talk in itself. But suffice to say that for people who are obese or overweight, hypocaloric diet, low carbohydrate diet, intermittent fast, Mediterranean diet has been well researched and found to be extremely valuable in treatment of these patients. Or that is a diet which basically is plant-based diet, high fruits, vegetables, avoidance of using the right type of oils and using the healthy foods and all that. So it is beneficial not only for the liver, for cardiovascular health as well. And this is an example of the Mediterranean diet. But let me come to this slide, which I think is very important. Weight loss thresholds and how they impact the MASLD. Now, if you lose more than 3% body weight, you can get rid of the fat inside the liver. If you lose more than 5% of your body weight, almost 50 to 100% of patients will have reduction in inflammation. MASH resolution occurs with weight loss more than 7%. And now the top, which is most important because we are trying to reverse the fibrosis. Weight loss more than 10% fibrosis resolution in about 45% of the patients. Now, this is better than any of the drugs which have also been recommended. This is much better. But then how many people are able to attain this is very different. Only 10% even in the American studies. So let's come to the pharmacotherapy, and I will not go into all the studies into each drug, but let me say that drugs recommended by scientific societies, vitamin E and pioglitazone, after the famous Pivens trial in 2010, got a sort of a nod, but never got a recommendation as a drug for treatment of MASH. The Indian Drug Agency and the Indian Liver Society have recommended saroglitazar, which is a dual PPAR agent for treatment of MASLD and MASH. Now, the most important drug which has come in has been approved last year, or only I think it was May 2024 by the FDA. And this drug is a thyroid hormone receptor beta agonist called resmetirom, not yet available in India, but this drug showed a significant benefit in reversal of fibrosis and therefore is likely to take this whole area by storm when it becomes available. Other drugs which are not approved but have data is there, metformin. GLP-1 is becoming very popular now, and one of the recent data on semaglutide is almost 43% reduction in fibrosis. And I think they will probably be submitting for approval from MASH. And let us see what happens with the FDA. SGLT2 inhibitors, DPP4 agents, obeticholic acid saw its up and down but never got an approval. Probiotics, data is emerging but still cannot be recommended. So just a word about the resmetirom trial, and you can see here this was the Maestro-NASH study where fibrosis reversal was to the tune of about 26%. And this is 100 milligram dosage. And NASH resolution was to the tune of about 30%. But I showed you 10% weight loss can improve by 45%. So wonderful results, and FDA approval is a great pat on the back. And I think the drug is going to be of great use. So what do our guidelines say? This is the Indian guideline, and they have recommended 3 drugs. Vitamin E, 800 international units per day. Now, we get the medicine or vitamin E in terms of milligrams. So how much is 800 units in milligrams? 600 milligrams. So that is about vitamin E. Pioglitazone. The evidence has become, over the years, there is a plenty of evidence now. But this drug, because of its side effect, has never become popular. But now in the West, I see, and many of our diabetologists are using it on a regular basis. And I think, this is a very, overall, a very cheap drug also, very easy to use. And if you select your patients carefully, I think this can be a very good choice. Saroglitazar, evidence, average, I would say, not great. We need more data on that. But again, the data is there, and it has been approved by both the drug agency as well as by the Liver Society. 4 milligram per day, minimum duration 1 year, but patients are continuing for longer period of time. There is improvement in insulin resistance, improvement in triglycerides, and there is improvement in hepatic steatosis, and some of the studies have shown that liver stiffness has come down, although biopsies, large biopsy studies are lacking. So the other statement I'll give is from the American Liver Society. Pioglitazone, they recommend for, they say, they don't recommend, they say may be considered. I think it's a very cautious statement. May be considered for patients with NASH in diabetics. Vitamin A, the same statement, may be considered for patients with NASH without diabetes. semaglutide can be considered for its approved indications, and approved indications are diabetes and obesity. But if the patient has NASH, then they say you can use semaglutide for NASH as well, because there is some benefit and there is evidence that it confers a cardiovascular and a renal benefit as well. And at the same time, they have very clearly said in the bottom line, available data on semaglutide, pioglitazone, and vitamin E do not demonstrate definite anti-fibrotic effect, and none has been carefully studied in patients with cirrhosis. So when it comes to cirrhosis, yes, that's very true. Now, therefore, I say in absence of clear recommendations, what do we do in our clinical practice and what we are looking forward to? Well, this is just next 3-4 slides. 90% of the patients are obese. Therefore, weight loss target of 10% should be advised for all patients. Calorie deficit diet of 30%, again, recommendations for all patients who are overweight or obese. Moderate intensity aerobic exercises and resistance training for all patients. Now, one thing is there, if the patient has cirrhosis, then the diet should have to be individualized to prevent sarcopenia, which is a very common problem in cirrhotics. And lastly, surgical or endoscopic bariatric should not be used as a primary modality for NASH. But if the patient needs it for the obesity indication, that's a different issue. So I have divided the patients we see in our clinics into a number of subgroups so that we have some practical insight into what we are doing. We may not be doing everything right, but at least we are doing something. Non-diabetic adult patient with MASLD MASH. Well, at the moment it's lifestyle, and vitamin E is used by a large number of people. Few people are going for pioglitazone as well. Now, on the right-hand side, I put down as evolving practice 2025. And resmetirom is going to be available hopefully this year. So what would happen in this category of patients? I personally think it will be lifestyle plus resmetirom 80 or 100 milligram per day. As yet, I am not sure how the costing of the drug is going to be. That will be one of the important factors. Now, what about diabetic dyslipidemia with NASH? Well, current practices, lifestyle, and this is probably one of the classical indications for saroglitazar. Diabetic treatment with GLP-1 agonist, SGLT2, advantage of weight loss and control of diabetes. So you can combine. Pioglitazone, again, I have kept as the last choice. What is the evolving practice? 2025, lifestyle. Now, resmetirom will come in here as well. Saroglitazar is probably going to keep its place, although it will be lowered down. And GLP-1 and SGLT2 will continue. This is how I foresee practice will evolve during 2025. What about lean NASH, which comprises of about 10 to 15% of the patients with NASH in this country? Well, at the moment, we give them very careful advice regarding exercise, muscle gain, avoiding sarcopenia, etc. Now, these are lean patients and relatively younger patients also. Pioglitazone might be a good choice over here because primarily it is the insulin resistance. Primarily, don't forget, it is the insulin resistance which is leading to lean NASH, and that is why this becomes part of the MASLD and not any other category. Therefore, pioglitazone, I think, is going to be a good choice. Evolving practice, how is it going to change with the introduction of resmetirom in this country? I think resmetirom will come in here as well. Now, this is a very important group, obesity and NASH. So at the moment, it is primarily lifestyle, and GLP analog semaglutide is being used widely now, starting from 3 grams, then increasing to 7 and 14. And I must say, I've used it in reasonable number of patients with very good results as well. And there has been, with the weight loss, I see reduction in the fibroscan values as well. Bariatric and endoscopic interventions, not because of NASH, but because of the primary indication of morbid obesity. How do I see the evolving practice in 2025? Well, I see that lifestyle has to be there. Now, what about combining resmetirom with the GLP analogs? Because in the Maestro trial, there were 14% of the patients who were on GLP-1 and received the resmetirom, and they did well. So resmetirom, GLP-1 combination, because the future is also going to be combination therapies. Now, another drug which is coming up, and I think tirzepatide, which is a GIP GLP-1, which has already received approval for diabetes obesity, and the paper about MASH has come out in New England Journal of Medicine in June last year. So that is showing a promising result, and I think tirzepatide, when it is available, will probably become a very useful drug because the degree of weight loss it causes is much more than semaglutide. And what I foresee is that once all these very effective drugs are there, then there is a reduced scope of bariatric and endoscopic interventions. Now, this is a paper which has been of interest, and we are waiting for larger trials. This is vitamin E improves transplant-free survival and hepatic decompensation among patients with non-alcoholic steatohepatitis and advanced fibrosis. And this is patients who are followed up, 236 biopsy-proven NASH, followed up for 10 years. Patients with cirrhosis were included, and they showed that vitamin E improved transplant-free survival and hepatic decompensation. What does that mean in clinical practice? Well, if you have a patient with NASH cirrhosis, and we are talking primarily of child A group, let's say. Currently, there are no recommendations in view of the limited evidence. Studies have also shown that metformin lowers the risk of hepatocellular carcinoma in patients with cirrhosis. So it remains a popular drug in this group of patients. A patient with, let's say, diabetes or pre-diabetes and has got cirrhosis of the liver, metformin is one of the drugs which is still being very commonly used. And now, although the study is only a single study, we wait for more results. Vitamin E in reducing decompensation and transplant need may be considered, but more extensive studies are required. Evolving practice in this area, I think we need further data. And based on the current studies, one cannot say anything. But in clinical practice, what do I do? Well, I have only two choices as of now. In a patient with cirrhosis, and I'm talking about NASH cirrhosis, one is use vitamin E based on the current data, or use SAMe, S-adenosyl methionine, based on a study which was conducted many years ago, but showed, and in patients with child's A cirrhosis, and showed that the transplant-free interval was greater than those who were on placebo. So in summary, what I have shown you that the risk of liver-related complications in MASH depends on the presence of fibrosis and cirrhosis. Early intervention is important to prevent progression of fibrosis or promote fibrosis regression. Lifestyle modification remains the key intervention. Always address comorbidities, diabetes, dyslipidemia, hypertension, obesity, and pharmacotherapy should be patient-centered. And I have told you or shown you different clinical situations and what should we try and use. But at the same length, the bottom line, I think, is that the THR beta agonist resmetirom appears promising and is likely to revolutionize the management of NASH this year or next year. Thank you very much.
Thank you for such a masterly oration on the subject, which is now so common. And aptly described that lifestyle modifications, weight control remain the cornerstone in the obese individuals. And this is very heartening to see that 10% reduction in the weight reduces the fibrosis. We were thinking earlier that once fibrosis is there, there's not much you could do. But now this is coming up, and this is 45% reduction is something which is
45% patients showed a reduction, even if it is by 1 point reduction, which means F3 to F2 or F2 to F1.
Whatever.
But that's a very important
very
finding.
important finding. So the talk is open for the questions if there are any, and from the centers also.
I think after the MASLD, people have gone for ALD.
Trying to catch everyone young.
But they are being caught there while they are young.
So if there is none, we close this session. Thank you.
Thank you.
Thank you so much.
Well, thank you, chairpersons and Dr. Upadhyay, sir. I request the chairpersons to felicitate Dr. Upadhyay. Well, thank you, Dr. Upadhyay. I will do the honors for paucity of time. Well, I will request Dr. Sandeep Garg to present the vote of thanks.
Well, on the behalf of Delhi State API, first of all, thankful to all the delegates for staying so long. I'm thankful to all the speakers master in their own fields, and thank you to all the chairpersons at all the satellite centers. And special thanks to all Delhi State executives for their support, and big thank to Sun Pharma, the makers of Pentocid, for their educational grant. Now dinner is open. Thank you.